little something for them cars that be bumping.
Yeah, but we need a beat that they can front to. Oh, that'll work. Be funky. You know what I'm saying?
Yeah. Feel it in your chest. Shit. This shit funky. I'm about to have a tension pneumothorax in this bitch. Oh shit. Feel a little JVD coming on. Oh, trauma to my thoracic. Cut that shit off, man. Cut it off, man. Now you gotta cut that shit off, bro. It's fucking up my ribs. Oh, I'm about to have a rib fracture. I feel a flail chest coming on. I'm about to have an open chest injury in this bitch. Oh, cut that shit off. Goddamn. Okay. Today, class, we are going to talk about thoracic trauma. All right, we're going to jump right into the shit. Okay, so everybody be ready. Here we go. Sit down, sit down. I need your attention, please. Take notes. The thoracic cavity, also called the chest cavity, is the cavity within the upper torso. Does that make sense? It should. It is separated from the abdominal cavity by the what? I'm proud of you, son. The diaphragm. The mediastinum is the section of the thorax immediately behind the sternum. I'm going to say it one more again. The mediastinum is the section of the thorax immediately behind the sternum. It contains portions of the esophagus, trachea, and great vessels, and the heart. The lungs lie on either side of the mediastinum. Despite the protection provided by bones and muscle of the thoracic cage, they're talking about your ribs there if you can't break that down, injury can occur when force is transmitted through these protective structures. Right. The organs within the thoracic cavity are protected on the anterior surface by the sternum, clavicles, ribs, and pectoral muscles of the chest. I just said, okay. Anyway, the lateral walls of the thorax are protected by the ribs, which extend from the spine toward the anterior surface of the chest. They're wrapping around. The ribs of the lateral walls of the thorax provide protection for the intrathoracic organs. Intrathoracic. What does intra mean? What does thorax mean? You know it. Break it down. But are susceptible to injury because they are not protected by muscle. The posterior wall of the thorax is protected by the spine, scapula, and posterior ribs. They said some real simple shit right there that they could have wrapped up in a sentence, but they wanted to break it down, all right? What we just got was an anatomy and physiology review of the thoracic cavity, all right? So they broke it all down for you and to a scientific level, in a sense, to a physical and an anatomical level. Anyway, next paragraph, section, the lungs and ventilation. All right, providing oxygen for cellular metabolism and eliminating carbon dioxide produced by cellular metabolism requires ventilation, right? The movement of air into and out of the lungs is what ventilation is, okay? And respiration. The exchange of gases. Let me read that again because I kind of messed it up. They give you a semi-definition of both, but the way I read it, it can be tricky, all right? So I know y'all are a little slow, so here we go. Providing oxygen for cellular metabolism and eliminating carbon dioxide produced by cellular metabolism requires ventilation, which is the movement of air into and out of the lungs, and respiration, which is the exchange of gases. Respiration consists of two phases. During external respiration, oxygen and carbon dioxide are exchanged across the respiratory membrane, composed of the alveolar capillary interface in the lungs. In internal respiration, gases are exchanged between the systemic capillaries and the cells of the body. Ventilation requires an intact brainstem, nerve pathways, and an intact chest wall, pleura, and lungs. External respiration requires adequate perfusion and ventilation and a small distance across which gases must diffuse. That is, the alveoli and pulmonary capillaries must be in close contact with each other. Internal respiration requires adequate unloading of oxygen to hemoglobin, adequate circulation to the tissues, and adequate offloading of oxygen at the cellular level. The thoracic cavity is lined with the pleura, which consists of what? The pleura is the what? It's two of them, right? Okay. Enough quizzes. The thoracic cavity is lined with the pleura, which consists of two layers, the visceral pleura and the parietal pleura. You should have known that already. You should have known it. I hope you did. The parietal pleura is the outermost layer that is in direct contact with the inside of the thoracic wall, while the visceral pleura is the innermost layer that is in contact with the lungs. I'm going to say this shit one more time because this always throws me off. I ain't going to lie. This get me all the time. I can't remember which is what and what the fuck. So here we go. The thoracic cavity is lined with the pleura. All right. The pleura lines the thoracic cavity, which consists of two layers, two of them. The visceral pleura and the parietal. Okay, let's get to it. All right, we already know that shit. Okay, the two visceral parietal, which is what? What the fuck? The parietal pleura is the outermost layer. Okay, listen again. Parietal, outermost. All right, parietal, outermost. P-O, outermost. All right, layer that is in direct contact with the inside of the thoracic wall, while the visceral pleura is the innermost layer that is in contact with the lungs. I just came up with a trick for us both. For us all. Fuck that. Parietal pleura, outermost. All right. P-O. Parietal, outer. All right. Visceral, V-I. Visceral, innermost. All right. P-O, V-I. P-O, V-I. V-I, P-O. And now we all know. Your ass slow. A potential space, the pleural space that is, lies between the two pleural layers. The pleural space contains a few milliliters of serous fluid that seal the layers to each other to allow expansion of the lungs on inspiration and act as a lubricant, reducing friction between the two pleura during ventilation. Preach. Okay, we have a potential space that lies between the two spaces, between the P-O, and the V-I, right? Okay, within that potential space lies a few milliliters of serous fluid, all right? I like to say serious because, I mean, that's all that's missing. Anyway, few milliliters of serous fluid, okay? And it acts as a lubricant, and it also seals the two layers together, all right? Imagine you putting up two pieces of paper and having water in between them. They're going to stick together, right? Right. All right. During inspiration, the diaphragm and the intercostal muscles between the ribs contract, increasing the volume of the thoracic cavity. The negative pressure created by an increase in the size of the thoracic cavity creates a negative pressure in the pleural space, which allows the lungs to expand, creating negative intrapulmonary pressure. All right, let's double back on that one too, because this is another thing. They say it so fast and it seems so simple, but when you get in front of that test, it's like, you know what I mean? That's the shit that gets you. So during inspiration, what happens? The diaphragm and the intercostal muscles between the ribs contract. That makes sense, right? Because you're using those muscles so they get tight, they tense up. All right, increasing the volume of the thoracic cavity. Okay. Why is it increasing the volume? Because you introducing air, right? Right. All right. The negative pressure created by an increase in the size of the thoracic cavity creates negative pressure in the pleural space. Why is it negative pressure? Why? Because you're pushing against that, right? The air ain't going into the pleural space. It ain't going in between those. It's going into your lungs. Your lungs is expanding. They're getting bigger. right? So it's pushing up against that pleural space, all right, which is allowing the lungs to expand, because if it didn't, then the lungs wouldn't be able to expand, right? All right, creating negative intrapulmonary pressure, right? As intrapulmonary pressure decreases, air moves from the higher pressure of the atmosphere through the nose or mouth into the upper and lower airways, filling the lungs, where external respiration takes place. During external respiration, oxygen diffuses across the respiratory membrane and enters the blood. And carbon dioxide diffuses out of the blood and enters the alveoli for expiration. During expiration, the diaphragm and rib cage return to their original positions, decreasing the volume of the thoracic cavity. The decreased volume creates positive pressure within the pleural and intrapulmonary spaces. Under high pressure, air flows out of the lungs and is exhaled into the atmosphere. There you go. I just did all of that. I just did all of what the fuck they was just talking about. That quick. Look. That's it right there. Anything that impairs the motion of the chest wall, contact between the pleural layers, the integrity of the lung, alveolar surface area available for exchange, or pulmonary perfusion interferes with tissue oxygenation and elimination of carbon dioxide. Makes sense, right? Basically, anything interfering with the process of you breathing interferes with the elimination of carbon dioxide, and that's hurting you. That's what gives you the, what do you call it, a hypoxia, basically. All right, next section, please. Let's talk about the heart. The heart is located where? At the center of the chest, just below the sternum, where it is fairly well protected. Even this book line, the heart ain't directly right there. It's a little bit shifted to your left. We all know that. All right. Anyway, the heart is responsible for perfusing the entire body with nutrients. You heard that? The heart is responsible for perfusing the entire body with nutrients, chemical messengers, and oxygen-rich blood, which bringing... Okay, I'm fucked up. Let's double back. The heart is responsible for perfusing the entire body with nutrients, chemical messengers, and oxygen-rich blood, and with bringing carbon dioxide back to the lungs for elimination. Boy, the heart is very important. Thank you, heart. In order to sustain life, the heart must be able to pump an adequate amount of blood throughout the body. An injury to the heart that reduces its ability to adequately circulate blood creates a life-threatening condition. The heart is surrounded by a tough membrane called the pericardium. One more again. The heart is surrounded by what? It's tough, and it's a membrane, and that shit is called the pericardium. Thank you, pericardium. The pericardium consists of what? 2 layers, not to be confused with the 2 layers of the thoracic cavity. But they kind of go, we're going to talk about this shit in a second. Let me go back and look at this one more time. Anyway, let me read on about these 2 layers. The heart is surrounded by a tough membrane called the pericardium. The pericardium consists of 2 layers. You got the visceral pericardium and you got the parietal pericardium, all right? Approximately 30 milliliters of pericardial fluid between those layers provides lubrication as the heart contracts and moves within the pericardial sac. All right, guys, let's go back. Now, what was we talking about? This is layered with 2 different layers too, right? We got both of them, the same thing, all right? We got the VI and we got the PO. All right. PO and the VI. Let's see which one, because I might be fucking y'all up. The pericardium consists of 2 layers, visceral pericardium and the parietal pericardium. Approximately 30 milliliters of pericardial fluid between those layers provides lubrication as the heart contracts and moves within the pericardial sac. All right, stay with me, y'all. Stay with me. The superior and inferior vena cava carry they didn't even break it down for us. I don't want to confuse y'all, so I'm not going to say which of those is the innermost and which is the outermost, because it might be opposite for all I know. But it did say that pericardium between these 2 layers. Okay, well, yeah, no, I don't say nothing in particular. Let's move on, all right? The superior and inferior vena cava carry deoxygenated venous blood from the systemic circulation back to the right side of the heart. Where does it carry you back to? The right side, because the right side is what? Deoxygenated. Let's go. Blood from the right ventricle is circulated to the lungs by way of the pulmonary arteries. Once the blood is circulated through the lungs for gas exchange, it returns to the left side of the heart via the pulmonary veins. All right, they're giving you the route and the rhythm. Blood leaves the left side of the heart to be circulated through the systemic circulation through the aorta. All right. The myocardium receives its blood supply during diastole. All right. The relaxation phase of the cardiac cycle. Diastole, diastolic, don't sleep. All right. Through the coronary arteries that arise from the aorta, just as it leaves the left ventricle. All right. Blood flow through the heart is controlled by valves between the atria and ventricles, and between the ventricles and the large arteries they supply. What is blood flow controlled by? Blood flow through the heart, rather. Excuse me, Pop-Tarts. Yummy. Blood flow through the heart is controlled by valves. Blood flow through the heart is controlled by valves between the atria and ventricles, and between the ventricles and the large arteries they supply. Let's talk about a general assessment and management of thoracic cavity. All right, this is your job. You got one of them. Let's get it right. Patients can sustain injury to the thorax, chest, through a number of mechanisms of injury, blunt and penetrating alike. You heard? For example, an unrestrained driver who is involved in a frontal impact, somebody just hit your shit, you just hit somebody's shit from behind or ran into a pole or something, is likely to strike his chest on the steering wheel. Wear your seatbelt, bitch. The impact may be significant enough to cause injury to internal organs of the thorax. All right? Penetrating trauma, you just got stabbed or shot, may cause injury to the internal thoracic organs as well. When a patient sustains a stab or gunshot wound, don't try to up me. The book be trying to up me. That's what the fuck I just said, all right? When a patient sustains a stab or gunshot wound to the thorax, injury to the internal organs is likely to occur. All right? Regardless of the specific mechanisms, injuries to the thorax can be classified as either open or closed. You got that? During your assessment, inspect and palpate the thorax on all sides, the anterior, the posterior, and lateral walls. When penetrating trauma is present, carefully assess the entire thorax so that you do not overlook additional wounds. You got that? Penetrating, meaning if they got shot, stabbed with a long-ass Ginsu Kung Fu blade, then you want to look at the front. All right, you want to check the back for an exit wound. You want to check the sides for an exit wound. They got stabbed in their side or with the Ginsu, long-ass Ginsu knife. You want to check the other side for an exit wound. Gunshot, so on and so on and so forth, etc., etc. All right? This is particularly, another one of the words they give me, particularly important, don't laugh, when the patient has sustained a gunshot wound. The bullet may have entered the anterior surface of the thorax and traveled completely through the patient, leaving an even larger exit wound on the posterior surface. Preach. Okay. So if they get shot in the front, anterior thorax, and it comes out the back, posterior thorax, you check the back, the exit wound, of course, will be larger than the entry wound. That's what they're saying, because that shit just went boom. General guidelines for the management of thoracic trauma patients include the following. Ensure an open airway, number one. You already know this stuff. This is your ABCs, your 1, 2, 3s, your basic shit, all right? Your BSI and all of that. Ensure an open airway. Assist ventilation as needed. Provide supplemental oxygen to maintain an SpO2 of at least 95%. Monitor ECG, SpO2, and ETCO2. Treat for shock when indicated. Throw a blanket on them. Consider the need for immediate surgical intervention and transport the patient to an appropriate facility, utilizing the most appropriate mode of transportation available. Now they're going to go to all of the scene size up and all of that good stuff, the stuff that we already know to do. But I'll go ahead and read it because on the test, they do give you situational questions. So let's go. Always ensure that the scene is safe. No brainer before entering it. This is particularly true when responding to any call that may involve violence. Identify the number of patients and call for additional resources as needed. Take a moment to ensure that the standard precautions you have selected are adequate to the situation. Consider the mechanism of injury, the MOI. MOIs such as falls, penetrating trauma, significant impact to the chest, and MVCs all have the potential to cause thoracic injury. Consider the need for manual stabilization of the spine. That's always a consideration. All right. Form a general impression of the patient. Sure enough. How does the patient look? Does he appear to have a decreased level of responsiveness? Does he appear to have dyspnea? Your general impression of the patient provides your first indication of how quickly you must prepare for transport. All right, let's talk about the second thing, the primary assessment, okay? Your primary assessment. A decreased level of responsiveness in a trauma patient can indicate traumatic brain injury, shock, or hypoxia. You got it? Decreased level of responsiveness in a trauma patient, that is, could indicate traumatic brain injury, shock, or hypoxia. If the patient is unresponsive and does not appear to be breathing adequately, immediately check for a pulse. If a pulse is not present, what do you need to do? I'm not even going to read that. If you don't know by that by now, you need to check your fucking self, all right? I'm just playing. If a pulse is not present, do CPR, okay? And if you didn't know that, it's okay, all right? It's going to be all right. It's going to be all right. Just listen to me a little bit more and we're going to get you where the fuck you need to be. You got me? If a pulse is present, continue on with your primary assessment. Ensure that the patient has a patent airway. Open the airway using manual maneuvers and suction as necessary. If those techniques are ineffective, insert a simple airway adjunct. Assess breathing and assist with the bag valve mask device. And supplemental oxygen if needed. Impaired breathing should increase your suspicion of chest trauma. Yep. Check the pulse and control significant bleeding with direct pressure. Administer oxygen to patients with an SpO2 less than 95. Poor initial impression, decreased responsiveness, inadequate breathing, or indications of significant blood loss. All right? That all of those patients you're going to administer oxygen to. So again, administer oxygen to patients with an SpO2 of less than 95%, with a poor initial impression, with decreased responsiveness, with inadequate breathing, or indications of significant blood loss. Give them O2. Maintain the patient's SpO2 at 95% or above. Maintain the patient's SpO2 at 95% or above. These patients are critical and a high priority for transport, no matter what they tell you at the hospital. Maintain the patient's SpO2 at 95% or above. All right, they little shit is a little different. Rapidly extricate critical trauma patients in vehicles. Make decisions about the need and feasibility for ALS response and air medical transportation early in order to get the resources en route to your location. Let's talk about the secondary assessment. The secondary assessment, I think we're talking about trauma here, right? Of course. So it's a rapid trauma assessment. That's what your secondary is in a trauma assessment. Look at your paper, bitch. Immediately after addressing issues with the airway, breathing, and circulation, perform a rapid trauma assessment. Not slow. What the fuck does it say now? Rapid. Not focused. Not thorough. A rapid trauma assessment, all right? Expose the patient and check the head, neck, chest, abdomen, pelvis, and extremities, whole body, for potentially life-threatening injuries. The rapid trauma assessment includes quickly palpating and auscultating the chest to check for injury and equality of breath sounds. Expose areas of the body as much as possible. Get them naked, bitch. Trauma naked. Given the circumstances, that is, So expose areas of the body as much as possible given the circumstances. You ain't just going to get them naked if they fucking foot got ran over by a car. You know what I mean? For example, it may be difficult to completely expose a patient who is entrapped in a badly damaged vehicle, right? In dim or dark conditions, use a flashlight, but plan for reassessment in adequate light. Look them over again. Signs of chest trauma include the following, all right? Pay attention. Listen. Signs of chest trauma include the following, okay? Cyanosis, tachypnea. I'm going to read this shit off like a graduation, all right? Signs of chest trauma include the following. Cyanosis, tachypnea, dyspnea, soft tissue injury to the thorax, including the anterior, lateral, and posterior aspects. Penetrating trauma to the thorax with or without the presence of a sucking chest wound. Decreased or absent breath sounds in a lung field. Paradoxical movement of the chest. Hemoptysis or bloody sputum. Subcutaneous emphysema. Jugular venous distension, or JVD, tracheal deviation, which is a late sign, and or shock. Y'all graduated, bitch. You made it. Immediately cover any open injury of the neck or chest. Okay? Do not forget that the back is also a part of the chest. Tell me why. Tell me why right now. Why? Why is it a part of the chest? Huh? Okay, meaning, you know it, you got it already. Congratulations, okay? Your ribs, of course, wrap around from the front to the back, all right? There's an anterior portion of the ribs, posterior portion of the ribs, also a lateral portion. So something that affects the front of your ribs could affect the back of your ribs, all right? That's what they just said. Wham, bam. Moving on. Secondary assessment. Vital signs. This is also a part, of your secondary assessment when dealing with traumatic injuries, okay? Also a part of that secondary assessment, vital signs, monitoring devices, history, and physical exam, all right? So you did your rapid trauma assessment, all right, then you move on to your secondary assessment, which includes your vital signs, also includes rapid trauma assessment, vital signs, monitoring devices, history, and physical exam, all right? For critical patients, the remainder of the secondary assessment is completed en route to the hospital if possible. If transport is delayed due to extrication or other factors, complete the secondary assessment on scene as soon as it is feasible. Obtain a set of baseline vital signs, including your pulse, respiratory rate, and blood pressure. Pulse ox is very valuable in assessing patients with chest injuries. You got it? Because you need to know about the blood flow, the amount of oxygen in the blood, of course. You know, their chest is hurt, meaning their heart could be affected, meaning blood flow could be affected, all right? Meaning breathing could be affected. So they're not getting that oxygen to the blood that it needs. And the blood circulation is not, moving the oxygen throughout the body, so on and so forth. Initiate continuous pulse ox as soon as possible. Damn, I just spit real heavy right there on the book. Oh, damn. Going to have to get it. All right. An ECG and ETCO2, if available, provide additional useful information. That's talking about the level of carbon dioxide in the body, of course, in the blood. Keep in mind that patients with thoracic trauma may have multi-system trauma. All right? Perform a thorough head-to-toe assessment, searching for signs of injury. Treat additional life-threatening injuries as soon as they are identified. Manage less serious injuries after the secondary assessment according to the resources available. For example, if you are by yourself with a critical patient and have a transport time of 4 or 5 minutes, you may not be able to apply dressings to minor wounds. Perform a head-to-toe assessment or focus assessment depending on the patient's injuries. Assess the neck, looking for JVD, jugular venous distension, tracheal deviation, TD, whatever the fuck, okay, or subcutaneous emphysema, SE. No, not really. Palpate and inspect the chest. All right. And where you want to inspect that chest and palpate that chest, you want to palpate the anterior, the front, the lateral, the side, and posterior, the back. And assess lung sounds for equality and adequate depth of ventilation. If the patient is alert and oriented, obtain a medical history en route to the hospital. All right. If they are alert and oriented, Sometimes people don't want to talk though, you know, so the book always make it sound so simple. But anyway, that's a whole other thing. Remember this for testing purposes, all right? For testing purposes, you're going to want to, if they are alert and oriented, you're going to want to get a medical history en route to the hospital. Got it? If the patient's mental status is altered, search for any indications of a medical history, such as medical identification jury, life alert, or medications in the patient's personal belongings. They be having the bracelets on and stuff like that, you know? Or the necklaces. Communication and documentation. Serious thoracic injuries require immediate physician evaluation and intervention, possibly including surgical intervention. For patients to receive that care, you must notify the receiving hospital as quickly as possible about patients with serious injuries or mechanisms of injury. Report the patient's age and gender, mechanism of injury, level of responsiveness, significant injuries and physical findings, vital signs, treatment implemented, response to treatment, and estimated time of arrival. Remember to request any specific orders for medical direction at this time as well. The hospital does not require a complete listing of injuries and findings in the radio report. Include what is pertinent to convey the urgency of the patient's situation so that preparations can be made if necessary. Fill in additional details on arrival, including any changes in the patient's condition since your radio report. Record the details in the patient care report, your PCR. Reassessment. Anticipate the potential for developing problems with the patient's ventilation and perfusion. Perform your reassessment every 5 minutes for critical patients and every how many minutes for non-critical patients, you say? Tell me now. Yay! 15 minutes. You are correct. I love y'all. Pay close attention to trends in vital signs and appearance for signs of patient deterioration. Check any interventions performed as part of the reassessment. Yeah. Types of thoracic injuries. The two general categories of thoracic trauma are open and closed chest injuries. You got it? You got it? Two types of thoracic injuries. General categories, that is, of thoracic trauma are open and closed. Open and closed. Open and closed. Close and open. Open and close. Let me reposition. If y'all want to, let's take this time to get up, stretch out, do a couple jumping jacks, a few push-ups, some finger stretches, rotate your neck. Oh, God, yes. Crank your back. Change the way you sitting or something. Take a sip of water, whatever. And we are back to it, all right? Open chest injury. An open chest injury is the result of penetrating or I messed up somewhere. An open chest injury is the result of penetrating or blunt trauma to the thorax in which the integrity of the thoracic wall is broken. Penetrating trauma may be the result of forces applied to the outside of the body, such as a bullet wound. An open wound also can result from blunt trauma if a fractured rib lacerates the chest wall. Okay? All right? So an open wound also can result from blunt trauma if a fractured rib lacerates the chest wall. They said it enough. It's simple. All right. Well, I'm just a little slow, so I had to double back. Damn. When an open chest injury is present, identify the mechanism of injury that caused the injury. If the patient has been stabbed, try to identify the weapon's length and the width. Doing so gives you an idea of the extent of internal injury. Bullet wounds can produce a small entrance wound, but can be accompanied by massive internal damage. Look not only for entrance wounds, but exit wounds as well. Failure to perform a thorough assessment may result in overlooking a life-threatening injury. Injuries that can accompany open chest wounds include injury to the trachea, esophagus, diaphragm, heart, and great vessels. Damage to these structures can result in a very rapid deterioration of the patient and result in death from hypoxia and massive blood loss. Help me. The active process of ventilation occurs as a result of decreases and increases of pressure within the pleural space. The active process of ventilation occurs as a result of decreases and increases of pressure within the pleural space, and lungs, causing air to enter through the nose and mouth. If an opening in the chest wall is approximately 2/3 now, 2/3. If an opening in the chest wall is approximately 2/3, the diameter of the trachea or larger, the pressure changes in the pleural cavity, allowing air to enter the pleural cavity during inspiration. This is not a good thing, people. When air accumulates in the pleural space in the presence of an open chest wound, it is called an open pneumothorax. Got that? These wounds also are called sucking chest wounds. Why? They're about to explain. Because as the patient breathes in, outside air is drawn into the thoracic cavity, making a sucking wound. During expiration, you may see bubbling of blood as air escapes through the wound. Why? Because of air, right? Right. It ain't where it's supposed to be, so it's not doing what it's supposed to do. The patient's ventilation is impaired by disruption in the integrity of the chest wall and the accumulation of air or blood within the pleural space. In such cases, you will immediately, okay? No hesitation. In such cases, you will immediately cover the open wound with a gloved hand, followed by the application of an occlusive dressing. Why is it occlusive? Occluded, meaning it can't be seen through. Nothing is being let in or let out. You understand? So you put that occlusive dressing over that bitch so it'll stop bubbling up. All right? You're stopping the sucking chest wound. All right? And sometimes you might have to burp it. I'm sure they're going to get into that later, maybe. But anyway, closed chest injury, burping it by opening, like a little flap on the side. I don't know if it actually burps, but whatever the fuck. That's what they tell us. Closed chest injury, closed chest injury. Closed chest injury is caused by blunt trauma. You must evaluate the mechanism of injury to appreciate the potential for injury to the heart, lungs, great vessels, trachea, esophagus, and or diaphragm. Right? You must evaluate the mechanism of injury to appreciate the potential for injury to the heart, lungs, great vessels, trachea, esophagus, and diaphragm. Patients with a significant mechanism of injury to the thorax have the potential to deteriorate rapidly because of the inability to breathe adequately circulate blood, or because of massive blood loss. Broken bones from blunt trauma may lacerate or penetrate internal organs, right? You just got a damn sharp object on the loose inside your body, which can cause massive internal hemorrhage. You're bleeding on the inside. Consider the following. A patient is struck on the ribs with a baseball bat. Ow. The impact does not result in penetration of the chest wall. However, a rib was fractured and driven into the liver. Damn. Evidence of a closed chest injury includes contusions and or fractures to the anterior, lateral, and posterior chest wall. That shit sounds like it hurts. You're going to be in some pain. You're going to need some crack, okay? Skip all the pain meds and all. Give me some crack. I need some heroin or something right now. Give me some meth right now. Do it. Stat. Specific thoracic injuries. This section covers specific thoracic injuries, their clinical significance, and the appropriate management of each of them. Rib fracture. Rib fractures can result from blunt or penetrating trauma. The ribs of the lateral chest wall are more vulnerable to fracture than the rest of the ribs because they are not as well protected by muscle. You got it? That's true, right? They got the little small muscle in between them, right? The intrathoracic muscle or whatever the hell it's called. That. The ribs are attached directly to the sternum. The ribs that are attached directly to the sternum are vulnerable to fracture, because a rigid connection reduces their ability to flex, resulting in an increase in fractures. Rib fractures can cause internal bleeding, severe pain, we know, hypoxia, and lung injury. If a force applied to the chest wall was significant enough to break one or more ribs, suspect underlying injury, okay? The force that was applied can be great enough to fracture the bone and force jagged, broken bone into internal structures, such as vessels and organs. Even without rib fracture, blunt trauma to the chest can transmit forces to the underlying structures, causing injury, such as pulmonary contusion. This is particularly true in children, whose ribs are pliable break, excuse me, and less prone to fracture, yet provide less protection overall to the underlying organs. Let's say that again. This is particularly true let me go back a little further so we can get the whole context of everything. Even without rib fracture, blunt trauma to the chest can transmit forces to the underlying structures, causing injuries such as pulmonary contusion. This is particularly true in children whose ribs are pliable and less prone to fracture, yet provide less protection overall to the underlying organs. So it all adds up. The presence of rib fracture increases the mortality rate of the thoracic trauma patient. In particular, fractures of the first rib and scapula are associated with higher mortality because the amount of force needed to cause those fractures increases the likelihood of underlying organ injury. Rib fractures can be complete or partial. Rib fractures can be Rib fractures can be complete or partial. Rib fractures can be complete or partial. I heard a little rhythm. Depending on whether the break extends through the bone. Rib fractures can be complete or partial, depending on whether the break extends through the bone. Rib fractures produce substantial pain, especially while breathing, which can result in hypoventilation and hypoxia. During the primary assessment, assess for and ensure adequate ventilation and oxygenation of the patient. Signs and symptoms of rib fractures. Woo, dragon. The following are signs and symptoms of rib fractures. Pain or tenderness at the injury site. Contusions. Open wounds. Yes. Crepitus. All right. If a complete fracture is present. That's what it has in the notes in the little parentheses. Crepitus if a complete fracture is present. All right. That's a sign and symptom of a rib fracture. If a complete fracture is present. Crepitus. Guarding. Pain on inspiration. Hypoventilation. Hypoxia and hypercarbia. All right. All of these are signs and symptoms of rib fracture. We're going to say them again for you. Okay. Pain, or we're going to read them backwards this time. Signs and symptoms of rib fractures include hypercarbia, hypoxia, hypoventilation, pain on inspiration, guarding, they hugging themselves, crepitus only if a complete fracture is present. All right. You won't know that, but if you, hear crepitus on palpation or whatever. Anyway, open wounds, contusions, or pain or tenderness at the injury site. Signs and symptoms of rib fractures. That's what that was there. All right, emergency management of rib fractures. Let's talk about it. There is no definite treatment in the pre-hospital environment for rib fractures. You heard? There's no definite treatment because we don't know what's going on the inside, right? We can't handle all of that. Your role when treating a patient with rib fractures is to maintain adequate airway, breathing, and circulations. The simple shit. All right, stick to your shit. Yeah, ABCs, 1, 2, 3s. Keep it simple, pimp. Get them to the hospital as soon as possible. Allow the patient to sit in a position of comfort. If spine injury is not suspected, the patient may splint the rib fracture by holding a hand over the site. Monitor the patient's ECG, SpO2, and EtCO2. Monitor their blood oxygen saturation and their carbon dioxide, basically. If necessary, you may apply a sling and sway to the arm on the injured side, which will reduce pain by limiting movement. Even though patients are often in significant pain, remember that pain management with nitrous oxide is contraindicated because of the potential for what? The potential for pneumothorax, okay? Let's move on. If pain severely limits ventilation, you may need to assist the patient with a back valve mask device to maintain adequate ventilation. Arteries and veins run along the inferior edge of the ribs. Laceration of one of the vessels can allow blood to accumulate to the pleural space, causing a hemothorax. If the patient has signs and symptoms of shock, expedite transport and obtain intravenous access en route to an appropriate facility. You feel me? Flailed chest. A flailed chest. My bad, I blacked out right there. A flailed chest occurs when 2 or more ribs are broken in 2 or more places, resulting in a segment being detached from the rib cage. You got it? 2 or more ribs are broken in 2 or more places, resulting in a segment being detached from the rib cage. Flail chest, that's what that is. The flail segment floats freely during inspiration and expiration, causing paradoxical movement of the chest. Initial muscle spasm following injury may prevent paradoxical wall movement. While the precise frequency of flail chest is not currently known, the American College of Surgeons estimate that level 1 and level 2 trauma centers treat 1 or 2 flail chest injuries each month. The number of flail chest injuries treated outside of trauma centers is not known. Well, duh, because it's outside of fucking trauma centers. Ain't nobody counting it, bitch. I mean, why? They could have kept that sentence. Paradoxical movement of the chest occurs when the flail segment appears to sink as the chest wall expands during inspiration. During exhalation, the segment protrudes. Don't judge me, bitch. I got a little southern twang. Protrudes out as the chest wall returns to its resting position. Flail chest is a life-threatening injury because it interferes with ventilation and often coexists with underlying injury. The amount of force necessary to result in a flail chest is usually significant enough to drive the flail segments into the lungs, resulting in pulmonary contusion or laceration. Pulmonary contusion is injury to the lung tissue that decreases the ability of gas exchange to take place, leading to hypoxemia. For external respiration to take place, the alveoli must be inflated, and there must be close contact between the pulmonary capillaries and alveoli. When lung tissue is contused? Oh, just learned a new word. Contused. It's bruised, basically. When lung tissue is bruised or contused, swelling and bleeding in the lung tissues occur. I know they usually say contusion and shit like that. They don't say contused. It's been contused. When lung tissue is contused, swelling and bleeding in the lung tissues occur. The swelling and accumulation of blood increase the distance between the alveolar walls and pulmonary capillaries, reducing gas exchange. The larger the injury, the more lung tissue is involved, the greater the decrease in gas exchange. Additionally, the flail segment will reduce the amount of negative pressure generated by inspiration, resulting in smaller inspiratory volumes. If the flail segment is large enough, it can lead to hypoventilation and hypoxia. All right? Now, signs and symptoms of flail chest. The following are signs and symptoms of a flail chest. Pain or tenderness at the injury site. Makes sense, right? Dyspnea, contusions, crepitus, paradoxical movement of the chest, and this is in parentheses that it may not always be obvious. Paradoxical movement of the chest may not always be obvious. Guarding, pain on inspiration, hypoxia, and or hypocarbia. All right, let's read that again. Signs and symptoms of a flail chest include hypocarbia, hypoxia, pain on inspiration, guarding, paradoxical movement of the chest, which may not always be obvious, and or crepitus, contusions, dyspnea, pain or tenderness at the injury site. All right. Emergency management of flail chest. When treating a patient with flail chest, your care will include immediately ensuring adequacy of airway, breathing, and circulation. Did they say anything complicated? Hell no. What they say? They said that your ass need to focus on the simple shit, your ABCs, and don't forget, you are not a damn surgeon. You don't need to focus on all this complicated stuff and try to worry about this, that, and the third. You need to focus on the ABCs, get them to where they need to be so they can hook them up to the right shit. Consider the use of CPAP or assisted ventilations for patients who exhibit signs and symptoms of hypoxia and hypoventilation, which you know you're going to need to call for ALS backup in that case, because you more than likely ain't gonna have no vent just chilling on your truck. All right. Okay, since I'm tired of fucking reading and you're probably tired of listening to me right now, we're about to take a break in the middle of this chapter, and when we come back, there will be a part 2 to complete the thoracic trauma chapter. Okay? All right, y'all have fun out there, all right?